Hello, my name is Tanzid Shams. I'm the Director of Neurology at Johnson City Medical Center. Today we're going to film a video that really demonstrates some of the frequently asked questions that goes along with NIH stroke scale. There are a ton of videos out there on YouTube and a ton of training material that can be used to practice the NIH stroke scale. However, whenever we're assessing neurologically disabled patients or acute stroke patients, there are many areas of question marks and gray areas. The NIH stroke scale requires multiple iterations to get really good at it, and often I find that both neurologists, neurology trainees, emergency room providers, nurses, ICU level providers frequently have questions regarding some of the subtle areas of NIH stroke scale. So the main purpose of this video is to really address all of the tools and subtle tips that you can use during the administration of the NIH stroke scale. I will go through each segment, all of the sections of the NIH stroke scale, and provide some pointers that I believe you'll find helpful when you're administering the NIH stroke scale. Okay, so let's begin with the very first segment of the NIH stroke scale, which deals with the level of consciousness. As we go through this section, there are three principles that are very important to remember. Often during the NIH stroke scale, you will be dealing with patients who are obtunded, may have weakness on one part of the body, may have speech difficulties. So here are three principles that are very important to remember. Okay, principle number one is to really assess a patient's ability to perform commands and tasks. Now, in a typical coma exam, we provide maximum stimulation to get the maximum arousability of the patient. In an NIH examination, it's a little different principle where we want to assess the patient's baseline health, in which case we don't want to prompt the patient too much. So after asking a question or after asking a patient to perform a command, what we want to assess is the patient's natural ability at that time, at that moment, to complete the task. Principle number two, it's very important to create some distinction between aphasia and dysarthria. The term aphasia means a person's inability to speak, and the term dysarthria means slurred speech. And these two concepts, it's very important as you go through the NIH stroke scale, it's important to keep in mind the person's ability to produce speech, receive speech, and so on, as well as follow commands. And we'll create examples of this as we go along. Principle number three. During NIH stroke scale administration, sometimes patient may not understand your command or the specific task that you're asking the patient to do. During those times, it is okay to demonstrate what you're asking the patient to do. Note, this is important because it's different than a typical neurological exam where you may not prompt the patient what to do. But for simple one-step commands during NIH stroke scale, it is okay to demonstrate some basic gestures so that the patient has an understanding of what's going on. The second segment of the NIH stroke scale has to do with horizontal eye movements. So it's important to note that a patient may not always follow a moving object or a bright object or somebody's finger, in which case it's effective to make eye contact with the patient and then move one's gaze side to side so that the patient can follow your eye movements. The human eye tends to make better eye contact with another set of eyes, and this movement can really help you assess any sort of gaze deficit that the patient may have. And the second way to assess this is through the oculocephalic maneuver. In other words, we would hold the patient's face like so, and then we turn the patient's head side to side. So under normal circumstances, the tendency for the patient is for the eye to come back to midline. But if there are any deficits, you'll be able to tell if the patient has any gaze paralysis. The next segment of the NIH stroke scale has to do with visual field testing. Sometimes you may find that a patient is not following commands in terms of counting fingers in different visual quadrants, in which case it's okay to assess response to threat. So for example, we have a patient, our wonderful Nurse Joseph, who's laying here, and I may try bringing my hand closely at a fast pace right towards his face, or from another angle, or from this angle. So this is a good way for us to check the quadrants of one's visual fields. So if you're having difficulty with someone not being able to follow commands or count the fingers in different quadrant, threat to visual field is a nice way to determine if the patient has any sort of neglect. Section 4, facial palsy. So here are some pointers that might be helpful when determining when a patient truly has any sort of facial asymmetry. Some of the key things I look at is how is the patient's upper half of the face and lower half of the face looking. So I look for wrinkling. Joseph, can you raise your forehead for me? Raise your forehead. So look at this area versus the lower half of the area. Okay, relax. In a stroke patient, only the lower half of the face should be involved. Typically, in a Bell's palsy patient, you might see flattening in the upper half of the face as well. Okay, Joseph, can you smile for me? Okay. As you can see, there are beautiful nasolabial fold here, and these are symmetric, so always be sure to compare both sides. Good, relax. You can also compare this with the driver's license or a picture that a family may have to get a sense of person's baseline. And then take a look at the angle and the positioning of the eye. That also helps me to determine if the patient's face is symmetric versus asymmetric. Joseph, close your eyes tight for a second. Good, and open again. Good. Okay, relax your face. And this just really gives us a nice comparison of the baseline and the eye positioning. And if you get a chance, comparing it to a standard ID like a driver's license can be very helpful. Here are some pointers on section 5 and 6 of the NIH stroke scale, which has to do with the motor strength of the arm and leg. These pointers will really help you during administration of the NIH stroke scale. So for instance, it's very important to do one arm and one leg at a time, and it's always a good practice to start with what we think is the weak or the hemiparetic side of the patient. So if we follow along and look at Joseph's body here, I'm going to prompt Joseph. Can you lift your left hand? Joseph, can you try to lift your left hand? Okay, it's unclear to me at this time if a patient can follow my commands, at which time it's okay for me to demonstrate for him. Joseph, can you lift your left hand for me? Section 7 of the NIH stroke scale has to do with limb ataxia. So finger to nose and heel to shin are common tasks that we ask patients to follow during this segment. However, here are two important pieces of information to keep in mind. For instance, a patient may not be able to follow your commands during this segment of the NIH stroke scale, in which case the score for this section would be 0 or normal. In other words, if you're asking a patient to conduct the finger to nose task and they cannot perform this because they're weak, then the score that they get is 0. And along the same lines, if the patient has total comprehensive deficit and they're not able to understand your commands, then the score that you'd assign for this section is also 0. Another good pointer or a tip for section 8, which has to do with sensory examination of the patient, is to use different types of stimulation. So for instance, your first attempt is always with some sort of a sharp object or pinprick to see if the patient is responsive. However, a patient may have a level of obtundation where they really are not responding to pinprick in different limbs, in which case it's okay to escalate a little bit of higher level of stimulation. For example, nail bed pressure to see if there's any sort of grimacing that's being generated. Often a stroke patient may not be arousable enough to give you very subtle information about sensory examination or really identifying whether it's a subtle area of the arm or leg or face that's missing sensory information, in which case general nail bed pressure to generate grimace or some sort of obnoxious stimulation to get a sense of facial expression or general sense of sensory feedback is sufficient. Section 10 of NIH stroke scale has to do with speech. We've talked about the distinction between aphasia and dysarthria. Aphasia is inability to speak, and dysarthria is slurred speech. But what if a patient is intubated by the time you're conducting your NIH stroke scale? It's important to understand that for an intubated patient, we do not score this segment of the NIH stroke scale. As long as you annotate that the patient is intubated, that is sufficient. The final segment of the NIH stroke scale has to do with extinction and inattention. A key principle that you can use is something called double simultaneous stimulation. So let me demonstrate this. Often a patient can be obtunded and they may not be following your commands very well. In a setting of NIH stroke scale, things can be very busy and hectic. So what we want to do is to ask the patient, Joseph, can you close your eyes? Okay. And once the patient has their eyes closed, now I'm trying to determine which part of the body patient can actually gather sensory stimulation from. Joseph, which side of your body am I touching? Where am I touching?
Right.
Good. Where am I touching you right now?
Left.
Good. So as you can see, double simultaneous stimulation can be a good principle to determine if a patient has extinction or inattention.